Good morning and welcome to the International Myeloma Foundation Pacific Northwest Regional Community Workshop. Today's date is October 9th, Saturday. It's about 21 degrees Celsius here in Los Angeles. As they say on the plane, that's 67 degrees Fahrenheit. So it's a beautiful day here, and I would hope that for all you folks up north, it'd be a beautiful day too. We are really thrilled to have a couple speakers here that I have known for a long time, but I need to go over our sponsors here. We have Amgen, Bristol Myers Squibb, Karyopharm, Jensen, GSK, Oncopeptides, and Takeda. With their generous support, we're able to do this webinar. As a follow-up to the workshop, the speaker slides will be available after they speak today. About 24 hours, they go up on our website. And I was thrilled to find out last time, we have about a good chunk of people here, but we had a whole bunch of people go to the slides after. So please do so, get your notepad out or however you take notes, and you'll be impressed by how much this is going to help you. But today, sit back, enjoy it. We got time for your questions. Just try to calm yourself and get into what's going on right now. We're going to do myeloma, all aspects of myeloma in today's talk. And what's important to me for you is to listen. It's hard to listen when you're a new patient. It's hard to listen when you're an experienced patient, but try to listen because these doctors are in the field and they know exactly what's going on and they're going to be able to help you. So without further ado, I'd like to introduce Dr. Cowan. He's with Fred Hutch. And I'd like to introduce Dr. Cole. He's with, Craig, Michigan State University. And Mary Steinbach is from Hutchinson Cancer Institute. So we have a lot of people here. Let's go over the agenda. Today, I spoke a little bit about us. The foundation has been in operation for 31 years. You can say we know what we're doing, and please feel that you can trust everything that we are doing. Andrew's going to start at about 10:05 in a few minutes, and he'll go over Myeloma 101 and Frontline therapy. Now, for those of you out there that think you've heard everything about 101, I promise you haven't. And I promise you haven't heard everything about Frontline therapy. And Andrew's going to rock us on that, make sure we get everything we need to know. 10:40 a.m., questions and answers. Doctors and everyone, please try not to answer while we're speaking. I'd like to save those questions. And then at 10:55, we have a new thing we're doing. It's a mindfulness meditation. Just takes a few minutes, and then we'll have a stretch break. And Kevin, that's about 10 minutes or so. So we got about 10 minutes there. And then we're going to have Dr. Cole come up, and he's going to talk about relapse therapy, very important topic, and clinical trials. What's around the corner? What's in front of us? How are we going to drive through this myeloma to help patients deal with it better? And then how to manage myeloma symptoms and side effects. How to handle myeloma symptoms and side effects. Mary Steinbach, who's on our Nurse Leadership Board, a very great program, and I believe it's in operation for 15 years now, where we get the best of the best. And we have here speaking with us today. So for those of you signed on right now, there's a lot of you, you're going to really have a great presentation today. So with that being said, Andrew, are you there?
I'm here.
Okay. Why don't you get started with your slide deck? Thanks, okay. Andrew.
Great. Thanks for the nice introduction. And also, I was looking at the audience list. Great to see a lot of familiar names out there. So thank you for joining. And for those I don't know, thank you for joining. I'm going to be talking today about myeloma frontline therapy and also kind of the myeloma 101 talk. A lot of this will be, old news to many of you, but I hope that even if that's the case, there's some new kernel of knowledge everyone can take away. So can we go to the next slide, please? So these are my disclosures. I'll just leave this here for a second. All right, please, next slide. Okay, so the goals, first of all, kind of going over again the basics of multiple myeloma. What is this disease? Why does it matter? How common is it? How do we diagnose it? And then talk about what kind of treatments we can give for patients that have a new diagnosis of multiple myeloma. And that is an area that is really evolving so rapidly, such that, by the time I finish this talk, some of what I said may be outdated. reviewing data on autologous stem cell transplant, also a very important part, we still think, even in 2021, for myeloma therapy, and then reviewing standards for maintenance therapy in myeloma. And before I start, I also just want to mention we had a big loss in the Fred Hutch community. Dr. Eli Esty, who's one of the leukemia doctors here, who is very well known, passed away last night. And I just wanted to mention that. So I know this is a myeloma meeting, but he was really a giant in oncology, and it's such a tragic loss. So anyways, I just had to say something. So let's move to the next slide. So what is multiple myeloma? Multiple myeloma is a plasma cell neoplasm. What is a plasma cell neoplasm? I think it's important when we think about any kind of cancer, it is always, what is the cell that the cancer comes from? And, so why it's important in multiple myeloma is not only is it important for, understanding the disease and how it affects people, but it's really important for designing therapies. When we understand the biology of the malignant cell, we can really better understand what its Achilles heels are and how we can target the cell. And so this stuff is really important to scientists, to biologists, to translational researchers, and to clinical researchers like myself. So myeloma is characterized by proliferation of malignant plasma cells. And what causes this, we don't fully understand. And this is unfortunately a common thread with most malignancies. The best example of a cancer where we know there's a clear link between exposure and development of the malignancy is lung cancer, and smoking rather, or bladder cancer and smoking, or certain exposures to radiation and development of things like thyroid cancer. But with multiple myeloma, there's not really, there's associations. For example, folks who work in agriculture, first responders to 9/11, firefighters, these are all occupations or exposures that are associated with higher risk of multiple myeloma, but we don't know exactly what about that, leads to developing myeloma. What happens in this disease is that you get a clonal population of the plasma cells that produce excessive amounts of antibodies. These are the antibodies that help us fight off viruses, bacteria, except in this disease, we have too much of it. And that's the M spike, the monoclonal immunoglobulin. We also see production of cytokines and other factors that interfere with bone metabolism. We see overproduction of light chains that lead to kidney failure, suppression of normal hematopoiesis or production of red blood cells, and also reduced immunity. Immune dysregulation is really the key. One common thing I've seen before people develop myeloma is they have a history of recurrent episode of shingles. That seems to be a common, when I ask folks, it's a common thread. Why? I think it just highlights this immune dysregulation, and certainly shingles is common in older people, and most people are with myeloma are over 50, but it does seem to be more common. So immune dysregulation is key. Next slide, please. So this just highlights, this is a slide that shows hematopoiesis. So what is hematopoiesis? It's the production of your immune system, your red blood cells, all the components of your blood from a single stem cell. And these stem cells are useful for stem cell transplant. These are the stem cells we use. They have the capacity to produce all the lineages of our immune system: platelets, erythrocytes, dendritic cells, macrophages, neutrophils. Everything can be produced by it. And you see here over on the top, the development of the stem cells into different differentiated cells that ultimately result in production of a plasma cell. Next slide. So I'm just kind of in this following slides going to go through the different tests that we obtain to diagnose someone with multiple myeloma. So what is an M spike? That's the first question, because your doctor will commonly talk with you about an M spike. The M spike is the measurement of the immunoglobulin molecule. What is the immunoglobulin molecule? That's shown here. It's an antibody. Antibodies are produced by plasma cells, and they're produced in response to either a foreign object or more commonly an infection. So when you get infected with a virus or a bacteria, what happens first is your plasmablasts rev up and they proliferate very quickly and produce huge amounts of antibodies. And these antibodies neutralize viruses and bacteria. This is such an important part of our immune system. And so this is what an antibody looks like. They have very high binding capacity to viruses, bacteria, or whatever the protein is that they target. There's 5 different types of antibodies: IgG, IgM, IgA, IgD, and IgE, and they all serve slightly different functions. One thing that's, kind of following from how I mentioned that the biology is important to understand, each of these antibodies has slightly different properties. IgM is a big molecule. So if we have too much of it, it can cause something called hyperviscosity. Patients with IgG versus IgA have slightly different presentations. So these can be important, and they're also important because usually when you have one of these antibodies or monoclonal proteins identified, it's usually always going to be the same one identified when the disease comes back. More on that later. So next slide, please. The SPEP is how we identify the plasma cells. Sorry, I'm just going to stop my video for a second because I think I have a bad connection here. All right, looks like I'm back. I'm good. So SPEP is a way to quantify how much immunoglobulin we have. And an SPEP is basically an electrophoresis gel that separates out proteins by their charge and size. And this is what a normal SPEP is shown in blue. And the peaks basically show the density at a specific site. So albumin is a common protein in the blood. Alpha-1, alpha-2, beta, and gamma. The gamma region is where we find the M protein. And if we see a spike in the gamma region, that's indicative of a monoclonal protein. Next slide, please. So one other thing I should mention about the SPEP is SPEP is just a way to quantify how much M protein we have. The immunofixation is the other really key test, and that is how we identify which monoclonal protein it is: IgG, IgA, and then also the associated free light chain. And so that's a nice segue to talking about a free light chain. So what the heck is a free light chain? Serum free light chains are part of the immunoglobulin molecule. They attach to the heavy chains, which are the inside portion that's longer. They're produced on a separate chromosome, and they're actually produced independently, and they're made into immunoglobulin molecules inside the plasma cells and secreted. But one thing that happens in multiple myeloma is these serum free light chains are overproduced. And that is one factor that can lead to kidney failure in multiple myeloma. There's only 2 flavors of free light chains. There's kappa and there's lambda. And they're measured by an assay called the serum free light chain assay. So one thing that's very important when we're testing for multiple myeloma at the time of diagnosis, serum free light chains have to be done at the time of diagnosis. They also have to be done when people are followed with their disease. Something I've seen even nowadays is that some doctors will only follow the M protein, not the free light chains. It's very important to always get both, because a free light chain that's above 80 milligram per deciliter or so is associated with a very high risk of renal failure. And that's considered something that would be sort of a urgent indication to start treatment for most patients. Next slide, please. So how common is multiple myeloma? It is the 2nd most common blood cancer in the United States, the 14th most common cancer overall. It is the incidence, which is an epidemiologic term that means how often it gets diagnosed per unit population, is about 7.1 rather folks per 100,000 people per year in the United States. There'll be about 34,000 cases in 2021. It's only 2% of all cancer deaths. Far few people are dying of multiple myeloma that are getting diagnosed. And the number of people alive with the disease continues to grow, which I think really speaks to how effective treatments are at keeping people going. I had a very interesting conversation just to highlight this recently with Dr. Tom Lynch, who's the head of Fred Hutch. And we were talking about myeloma, and he's been an oncologist for a long time. And one thing he said to me, which really struck me, and we hear about this all the time, he said, when I was in fellowship, the lifespan of multiple myeloma patients was 2 years, always 2 years. Everyone got melphalan and prednisone, and no one lived more than 2 years. So the fact that we have patients, and we'll get to this later, that are living 10, sometimes 15 years with the disease is really, to me, incredible, and really highlights how much the science and research has helped improve the outlook. Next slide, please. How does myeloma present? So these are some of the symptoms folks can present with. Anemia, very common. Most patients will present with anemia. That just refers to having a low red blood cell count. Bone pain. The most common reason for bone pain is a fracture. What causes fractures in myeloma? The bone gets weakened because of excessive production of bone turnover proteins, but also because of these lytic lesions. The lytic lesions are areas where the bone is being eaten away, often by a tumor, sometimes by what we would call that a plasmacytoma. Elevated creatinine is common. That's due to the free light chains. We call that myeloma cast nephropathy. And then high calcium, which is caused in part by bone turnover. Next slide, please. Here are the CRAB criteria, and this is a mnemonic doctors use to remember the key features of multiple myeloma. So you will sometimes hear this. Next slide. The diagnostic criteria for multiple myeloma are shown here. This has been the most recent iteration since 2014. So in order to get diagnosed with multiple myeloma, you have to have bone marrow plasma cells over 10%, or a biopsy-proven plasmacytoma plus the CRAB criteria, which we've talked about. There are some other features that are considered consistent with myeloma that were introduced in 2014 and are now part of our regular practice. Having a high serum-free light chain involved to uninvolved ratio, greater than 100, one or more focal lesions on bone marrow MRI, and greater than 60% clonal plasma cells in bone marrow examination. So it's possible someone could get diagnosed with multiple myeloma and have none of the CRAB features, and your oncologist might recommend starting treatment. And that can be kind of a tough pill to swallow, but I would say, it's a good thing to catch it early. People who have these features, almost all of them end up developing multiple myeloma or needing to start treatment in the next year. So really, I really like to think of these biomarker-driven criteria as a way to treat the disease before something bad happens. And so that's why I really think these are so important. And there may be others that get added in the future. We are learning a lot about this disease constantly, and what kind of factors predispose people who have the precursor condition, smoldering myeloma, to getting myeloma more quickly. Next slide, please. So I just want to review quickly some of the imaging modality tests that we can do. Bone marrow MRI was mentioned. This is a test that your doctor may order. MRI is more sensitive for detection of bone involvement than a skeletal survey. The skeletal survey, which is all the x-rays, we call it an osseous survey. That is a really outdated study. I should have included a slide here, but I didn't have enough time on whole body CT. And I think it's worth a mention. Whole body low dose CT is rapidly replacing the skeletal survey as an imaging modality for detection of lytic lesions. In my opinion, there's really no reason to do an osseous survey nowadays unless it's, we're in a resource limited setting and we can't get it, or it's something we can get on that day quickly. But an skeletal survey with a CT would still be indicated. MRI is important, but it's important to know that it doesn't really show, so we have, in our bone, we have two parts. We have the cortex, which is the hard part, and then the inside, which is the medulla or the marrow, and that's where the bone marrow forming elements are. And what MRI can show is those soft tissue lesions inside of there. MRI is also really good at detecting spinal cord compression, so that's something CT is not quite as good at. MRI is also less helpful for determining response to therapy. So next slide, please. So PET CT is really, I think, one of the most important, in my opinion, modalities we have to monitor treatment and also for diagnosis. PET CT combines two modalities. We have a PET, that's a nuclear imaging study. That's a test where we give you a tracer, and then we take a picture with a camera that can show where the tracer localizes to. And the tracer goes to spots that are growing quickly, like cancer. So we fuse that with a CT. So kind of like the low dose whole body CT we do for lytic lesions, we can do that with a PET CT, and we fuse it together and we get a picture that shows not only if there's destruction of the bone, but also if there's activity. So the PET CT is a really important modality. It's one that I really prefer at diagnosis and then for monitoring response to treatment. Next slide, please. So the other important test we get at the time of diagnosis is a bone marrow biopsy. A bone marrow biopsy is a procedure where we take a needle, we stick it into the hip bone, the iliac crest, and we take out not only a sample of the bone, a small sliver of the bone, but also some of the liquid bone marrow. And that's really, really critical. Even if you had a tumor and they stuck a needle in it and they said it's a plasmacytoma and they otherwise thought you had myeloma, you still got to get the bone marrow biopsy. And because the bone marrow biopsy is where we get not only the flow cytometry, which tells us if there's an abnormal plasma cell population, but also the FISH. What is FISH? FISH is short for fluorescent in situ hybridization. It is a test where we look for chromosomal changes in multiple myeloma. Think of this as a type of genetic testing, looking for changes in the genes. And there are certain changes that are associated with poor outcomes, and we call that high risk. And so you'll hear your doctor talk a lot about high risk myeloma, and the ones that are considered high risk are 414 translocation, which is the third one, and del17p. The other ones that aren't listed here are translocation 1416 and translocation 1420. And so these are really important to know. Sometimes they might change what we might recommend for treatment. Next slide, please. So another way to look at prognosis in multiple myeloma is the revised international staging system. And the way we stage myeloma is shown here. It's different from like staging for breast cancer or colon cancer, where we look at the anatomic spread. So we look at where the lymph nodes are. This is more about prognosis. So we know that the patients with stage 3 myeloma tend to have a more aggressive disease course than the patients with stage 1. And so the scoring system is shown here. I'm not going to go over it, but you guys can look at this in more detail on my slides later if you wish. Next slide, please. So again, this is talking a little bit about high-risk myeloma, and I harp on this a lot because this is really where we need to see the most progress. People with standard risk myeloma, this disease is these are the patients that often live with this disease for 10, 15, even 20 years. High-risk myeloma is a different disease. It's more aggressive. The treatments work, but they don't work for as long. It's about 20-25% of patients who have myeloma. And so we really need new strategies to try to figure out who the high-risk patients are, because even our current systems aren't perfect, and get better treatments for them that can overcome the nature of the tumor to be more aggressive. Next slide, please. So here is a depiction of one potential way of thinking about how we treat multiple myeloma. I'm going to go into some of this in the slides to come. This is not going to be an exhaustive talk, but I really just want to kind of highlight some of the key advances over the past few years, and also what the standards are. So for a patient that's eligible for a stem cell transplant, we would start out with 3 or 4 drug combinations, including a proteasome inhibitor like Velcade or carfilzomib, an IMiD like Revlimid, or a CD38 antibody like daratumumab, or another one that's now approved is isatuximab. Autologous stem cell transplant, which is a procedure where we give high-dose chemo followed by reinfusion of stem cells, is I think most in myeloma specialists in the US would still recommend that. Even though these new drugs are very effective, the transplant increases the depth of response and how long people stay in remission. And then after transplant, we recommend maintenance for all patients. And maintenance is, the idea is just, we're giving a treatment that would help keep the myeloma under control for longer, but a lower dose, so better tolerated for the most part. For patients who aren't eligible for transplant, we generally recommend 2 or 3 drug combinations like the above, but without the transplant. So you just go straight to maintenance. And then supportive care, which includes things like drugs for prevention of infection, prevention of blood clots, and improved and reduced risk of fractures, we would generally recommend a bisphosphonate. Next slide, please. So I'm going to skip over this because I've taken a little bit too much time. So let's go to the next slide. So here's a list of the approved drugs in multiple myeloma. And I really showed this just so you can get a sense of how much this has changed. If you had shown this slide like maybe 30 years ago, you would have just seen melphalan and prednisone. And again, everyone lived 2 years. And so this is really speaks to how much the science and clinical research and investment from, not only the NIH, but also from biopharma has really helped to accelerate the treatments that are available for patients. And I put in red the ones that have been approved this year. So already, well, over the past year, these 3 drugs, belantamab mafodotin, which is a BCMA antibody drug conjugate, melflufen, which is an alkylator, and idacabtagene viclucil, which is a BCMA CAR T, are now approved. And we may even have another CAR T approved for multiple myeloma later this year. More to come on that. Next slide, please. So a couple of things that I just want to update everyone on. So the standard induction, we would start with Revlimid, Velcade, and dexamethasone. For many years, there was a debate in the myeloma community about carfilzomib, Revlimid, and dexamethasone. Carfilzomib is another proteasome inhibitor. And for many years, people said there were those who thought that carfilzomib might be better. So this was a study that compared RVD to KRD, and this was run by a cooperative group study. This is a cooperative group trial, so that means it's funded by the US government. It's rolled out to not just academic centers, but community centers. And so patients were randomized to get RVD or KRD, and then subsequently randomized to get RVD maintenance at 15 milligrams for 24 cycles, or indefinite Revlimid maintenance. Next slide, please. Interestingly, that study did not show a difference between RVD and KRD. Unsurprisingly, they did see that there was more neuropathy with RVD, which is not shocking to me, and slightly more cardiovascular events and renal failure with KRD. But overall, in terms of their efficacy at getting the myeloma in remission and keeping it there, they're pretty similar. So I think there may be other studies looking at this that could change how we think about this, but for now I would consider them roughly equivalent. And this would also give one some impetus to choose KRD for a patient who, say, had neuropathy already and couldn't get RVD. It's at least as good as RVD. Next slide, please. So what else is hot and new in myeloma? The other thing you might be hearing a lot about is 4 drugs. So that's the idea of adding daratumumab, a CD38 antibody, to the upfront treatment of myeloma. One of the studies that was done in the US was the Griffin study, which was a randomized phase 2 study of Dara-RVD versus RVD for patients who were eligible for transplant. And basically, this is a schema of the study, and it shows kind of how patients were treated as they went on the study. Next slide, please. This study did actually meet its primary endpoint. The primary endpoint is, what that means is they designed the study to answer a statistical question. In this case, what percentage of patients have a stringent CR after getting consolidation? And for the study, they showed that there was a higher percentage of patients who had a stringent CR who got daratumumab. And so, there do seem to be quite deeper responses, more MRD negative responses. And so this is evolving, but this is something that I think, in many parts of the country, myeloma specialists are using this for all patients with multiple myeloma. The only reason I say it's evolving is because it's not everywhere. There definitely those who do not use this for everyone. And some people only use it for high-risk patients. So I think with more studies that are currently being done and seeing the results of those, we will hopefully get some better clarity on how we should be using this very powerful treatment. Next slide, please. And this just shows, the deepening of responses over time, which was much more with daratumumab combined with RVD. Next slide. So to summarize, induction therapy, the addition to daratumumab to RVD results in a higher proportion of stringent CR, also increased rates of MRD negativity. What is MRD? That could be a whole 30-minute talk in and of itself, but that's minimal residual disease. And basically, this is important in people who've had no evidence of multiple myeloma after getting their initial therapy. We can use a genetic test, testing for the gene rearrangement that's found in multiple myeloma, and we can detect myeloma at a very low level. And if we don't detect it by that modality, we call that MRD negative. And so, and the reason why that matters is because there's substantial data that achieving an MRD negative response is really a very powerful prognostic sign with respect to overall survival and time to your next relapse. So it's a really important test. In my practice, I have generally used DARA-RVD in high-risk patients where achievement of sustained MRD negative state is very critical, and those high-risk patients are shown here. But I think there is, again, not uniform consensus about this, even at our center. Next slide, please. So for patients who are not eligible for transplant, and I can show a slide about what eligibility looks like. We would generally use a lot of the same treatments we would use for transplant eligible patients, with the exception that we wouldn't do a transplant. For those who are older, more frail, 80s, in their 80s or 90s even, I've treated patients in their 90s, we would often consider a doublet, like Revlimid and Dex or bortezomib and Dex, and we would use a much lower dose of dexamethasone because, as you all know, dexamethasone can often be the hardest part of myeloma therapy. Next slide, please. What about autologous stem cell transplantation? I think, I'm somewhat biased because I come from a center where we've been doing transplants for, over 4 decades. But, I think that many still feel that that transplant for myeloma remains a cornerstone of management. All of the major randomized studies have shown a benefit for progression-free survival, which is a measurement that is a rough measurement of how long someone stays in remission. I generally recommend early transplant rather than delayed transplant. And transplant, can be a toxic treatment. We're giving high dose of melphalan, which is a toxic, chemotherapy when it's given at very high doses. But we've really gotten the supportive care down very well. We, at Fred Hutch, for example, we have a whole team of people that's all they do, and it's that way at all transplant centers, in fact. And so there are bad outcomes occasionally, but it's very, very uncommon. And all of these acute regimen toxicities are mostly manageable. Next slide, please. What kind of factors determine transplant eligibility? I think it's important to note that age is not an absolute contraindication. We have transplanted patients up to 75 at Fred Hutch, but there was a recent paper published last year, and they showed that when patients are selected appropriately, meaning they don't have a lot of comorbidities, they have a good level of fitness, transplant is just as effective for someone at 78 as it would be for someone at age 60. So I don't think that age should be an absolute contraindication, although for most people, as we age, we have more health problems. And so that is one reason why age, it does correlate with some of those factors. Patient preference is very important. I try to always have a thorough, informed discussion with patients about, the pros and cons of transplant, the side effects. And, if someone told me they didn't want to do a transplant, that's fine. This is not a curative treatment, but it is a very effective therapy and more effective when given early. But other factors that are important: caregiver, occupation support system, and residence. Next slide, please. in the interest of time, since I only have, I think, a minute left, I will skip over this, but these were just data that still show a benefit to transplant, even with longer follow-up from the IFM study and also from the Forte study. Next slide, please. Revlimid is the standard maintenance for patients after transplant. It improves progression-free survival, and in a meta-analysis improves overall survival. So Revlimid maintenance would just be a dose of usually 10 milligrams a day, often escalated to 15 and continued indefinitely. And it may work in part by helping the immune system recognize the cancer and keep it under control. That's one hypothesis for why this might work. Next slide. Bortezomib is another option. We have tended to prefer it for patients with high risk, although to be completely honest, these days for high risk patients, I have shied away from Velcade maintenance on its own, but there is some literature that supports it for the del-17p or 414 translocated patients. Next slide. This is the approach that I generally take, and if you advance it, I think there's an animation here. RVD maintenance is the approach that I've generally taken. That was studied in the SWOG S1211 study. And we would generally continue RVD for 2 to 3 years and then de-escalate to Revlimid. Next slide. So I'm done. I think I only went a minute over, Kelly, so hopefully that's all right. I think it's clear that outcomes are improving for newly diagnosed multiple myeloma. And I think it's really important to consult with an MM specialist at some point. Even, we all love our community oncologists, and that's great, but they also do see everything. And so it's really important to get an MM specialist. They can see you once, they can see you a few times throughout, and just weigh in, because things are changing and you want to make sure you're getting the best treatment and taking advantage of all the drugs that we have approved that can help folks live longer. Transplant is still a really important part of treatment, and the addition of CD38 antibodies may improve outcomes. We are seeing increased rates of MRD negativity and deeper responses that tend to result in better longer-term survival. So with that, I will finish. Thank you so much for your attention and for joining us today.
Come on. That was excellent. We got in at 10:37. Thank you, Andrew. That was fantastic. Oh, and Dr. McHale texted me about the meeting. He says, hello. So I hope you get that there. People, that was a really, really important conversation. So you do want to take a look at the recast of that on our website at myeloma.org. Now, we got some questions here, and I'm going to read off a few, and then I'm going to talk about a few. The first one is for the doctors. My myeloma specialist mentioned that there are thoughts about stopping maintenance 3 years after the SCT. If I remain in complete remission at the 3rd year mark, what are your thoughts? Anyone want to take that? Dr. Cole?
I think, there was the Stamina trial that was really one of the largest randomized trials in the United States with multiple myeloma. And in that trial, it found that between going after transplant, going straight to Rev maintenance versus consolidation versus second transplant, that all arms were equal, and going straight to Rev maintenance was kind of the best thing, or was the easiest thing. There was a second part of that trial that was resulted, I think, last year at ASCO or ASH, I forgot which one, where there was a second part of that trial where patients were able to they're given the choice of either stopping their Rev maintenance after 3 years or continuing on longer. And the results of when people, and this is all comers, so not just people that were in CRs or complete responses, but everyone. But the patients that stopped after 3 years tended to relapse sooner than the people who stayed on. And so I think right now, I'm still recommending patients can continue on. There are other trials looking at especially MRD status in patients who are MRD negative de-escalation of maintenance therapy in that group. But those trials take a long time to result. And so we're still gonna have to wait on that. But I would say that based on the stamina trial, I was really hoping for that 3-year mark to kind of pan out, but I think I'd stay on.
Okay, that's Andrew, you were nodding your head a little bit there. Is there anything you'd like to add to that?
Oh, I agree. I think Dr. Cole very eloquently stated the trial results that inform our practice. And I'm in the same boat. I mean, yeah, Revlimid can be tough to tolerate, and a lot of the toxicities can be very cumulative. It may be easy in the beginning. It may not be so easy after 6 years with diarrhea and neutropenia, and so it can be tough. And so hopefully we will have, some guidance from these studies, like the Dramatic study, which is an MRD guided therapy that's run by the SWOG group, but also the Auriga trial, which is an MRD guided therapy that's sponsored by Janssen. And so I hope that these can help guide our practice better using MRD.
I'll have to tell my daughters that someone used the word eloquent in my name in the same sentence. This is recorded, right? So I could.
It's recorded. All right. A newly diagnosed patient has asked, how important is kappa-lambda ratio in diagnosis and deciding treatment options? Anyone?
Well, I guess, I showed the slide about the diagnostic criteria and how if the ratio is greater than 100, we would often consider that myeloma, and, we don't have to be dogmatic about it. There are, patients who are in our clinic who that's the only thing they had, and they were diagnosed before the 2014 criteria, and they didn't want to get treated because, for example, they're an airline pilot and they would have to quit their job. And some of them didn't progress for a while. So, these are not, these are not crystal balls, but they're good tools. And I think for most patients, for the vast majority of patients, if your free light chain ratio is greater than 100, that would be, something not to ignore. And I would usually, recommend starting treatment soon after we confirm it. Of course, you would repeat it a couple of times. But what you don't want to do is play that chance of is something going to happen over the next 2 years? Because it's not like, you're following with your doctor, but it's not like they can see you every day. And I have seen people, they get seen 1 month, the next month they show up, they've got, lytic lesions, and it happened quickly. And so I think if you have this opportunity to treat, and it would be, something, usually it's something that would be beneficial, in my opinion. So the kappa-lambda ratio is important. Also the absolute level of the free light chains, how high it is. If it's really, really high, that's like, for me, an emergency. I send people in the hospital and I start treatment because those patients can end up in kidney failure really quickly.
All right. I have a one from the audience. This person is dealing with the side effects of carfilzomib. He's on, or they're on, a maintenance carfilzomib 1 day every week. And in the evening of carfilzomib, he gets the chills, sometimes with low fever, and often lost appetite. He takes Tylenol, Pepcid, Zofran as pre-meds, and additional Tylenol. The next day I'm tired, but other than that, I've any ideas about a better way to take carfilzomib? Craig?
No, sometimes I'll let Mary speak because she was just about to say something.
Oh, I didn't. I'm sorry. Mary,
Oh,
go ahead.
That's okay. Thank you. Yeah, I was going to jump in because I think this is described by a lot of patients, and we certainly see patients who have this reaction after carfilzomib. I think taking Tylenol is a good thing. It sounds like the meds this person is taking is really kind of the whole boat and trying to manage most of those symptoms. So I'm not sure there's much more to add other than sometimes people benefit from a little bit of fluids with their carfilzomib. And we often do this early when we initially start the drug. You always have to consider what the patient's cardiac status is, and you certainly don't want anyone to ever get overloaded. But sometimes a fluid bolus, even late in carfilzomib treatment in the maintenance setting, can help with some of these symptoms. And then lastly, just recognizing that, this is what's occurring every week, and it's how you feel, or every other week when you're getting your dose. And so just knowing that it's probably a part of it.
Okay, that's a great answer.
Sometimes
Greg?
lengthening the infusion. I've had the carfilzomib run a bit longer, but totally, and has helped with some of the symptoms. But just like Mary said, that those fluids and drinking lots of fluids when you get home can really help with that.
I have a question from the audience. I heard about mass spectrometry. Is this available now, and how does it differ from other tests? Anyone? Craig, you're smiling. Andrew, you're smiling. Who would like to take this one?
I love mass spec, and in fact, it was interesting. And what mass spec is another way to measure the M protein. And it's we've been doing this serum protein electrophoresis that Andrea talked about for I think 50, 60 years. And we've been doing a light chain test for, I think, 15 years. And mass spec is a super sensitive way to measure M proteins. It at least here in the Midwest, Mayo Clinic does mass spec. The only place that we use it is with patients that have non-secretory myeloma, that their myeloma is so mutated that we can't pick it up on the light chain test, and sometimes the mass spec can pick it up. But it's a super sensitive way to measure M proteins.
I see. Another one for the audience. Can you talk about diffused weight MRI for monitoring disease during maintenance therapy?
Yeah, I think, really what is diffuse weight MRI? This is just one of the, techniques they can look at when they do an MRI scan. I mean, this would be a standard modality, but, I tend to prefer PET scans just because I find the information more useful. And I also find that MRI tends to not show resolution quite as quickly. And so you can see the lesions get better on MRI, but it can take sometimes, quite a long time. So I think it's fine to get, though. I'm not saying it's like, a bad modality. I personally have found PET scans to be more useful. And so I don't order many surveillance MRIs in my practice. Sometimes I might alternate. I mean, if someone's got like high risk smoldering myeloma and they're not getting treated, I might alternate PET and MRI, because you could make a myeloma diagnosis with MRI too, and not find it on PET. But usually there's good concordance between the two.
Here's a big question. Why do you prefer Revlimid versus Velcade for maintenance, or the other way around? Craig, you're smiling.
I gotta stop smiling. There was a lot of the studies in standard risk myeloma have been using Revlimid as maintenance therapy, and it's a bit easier to take a pill. There was a study that was a long time ago called the Cowan study that looked at high risk myeloma and found that there was a benefit to Velcade, the proteasome inhibitors, over the IMiDs for higher risk patients. And just like Andrew had shown in his slide, that's been translated in a lot of other trials that have looked at for high risk myeloma using proteasome inhibitors, either as a singlet or as a doublet with Revlimid, because it's tougher to keep those high risk patients in remissions post-transplant. And Revlimid just doesn't seem to cut the mustard as much, at least historically, as the proteasome inhibitors.
I see. Let's go into some COVID stuff. I just lost the question. It was sent to me. Excuse me. Is it on here, Kevin? All right, let's go to this one. Any concept or comments in the concept of remission, and does anyone agree?
I mean, I think there's good agreement about what a remission is. I mean, we reviewed all the tests, the SPEP, the free light chains, the bone marrow biopsy, the PET scan. I think the one nuance can come with, the free light chains in the SPEP. Sometimes after a transplant or after treatment, we might still see a detectable M protein. And it's really important, especially for the standard risk patients, don't freak out about it. It doesn't have to be 0. I have a patient who had a transplant 4 years ago. He still has an M protein of 0.1, but he has no clinical evidence of disease. So it's important, if you see that M protein, you gotta look for evidence of activity, like a PET scan, and making sure they're not anemic or anything. But kind of think of it like MGUS. We've turned this back into MGUS, and so let's just watch it. And like I said, I've had a patient who's had this for like 4 years. I've also had patients that have gotten into CR after 3 months, and then it comes back 3 months later. So there's a lot of, as much as we think we have this figured out, there's still a lot we don't know. And just one test does not, there's not, one ring to rule them all. This is not Lord of the Rings. There's, this is a lot of nuance with these tests. And this is why you need an MM specialist, I think, frankly, because you'll have, some community oncologists will look, and I'm not trying to cast shade on community oncologists by any means, but you look at the M protein, it's up, you're like, oh my gosh, I got to treat, it's 0.2. And it's like, no, just, hold on, stop the cavalry. Like, we gotta, let's just think about this a little bit before we just start throwing drugs at people.
Okay. All right. I found my COVID questions. So what's coming up is with this person, there's asking, what is the recommended timing in between myeloma treatments for getting the COVID vaccine booster shot while in treatment? So they've had their 2 shots, and now they're wondering when it's a good time to do the booster for myeloma. Mary, do you have anything you'd like to add to that?
It's really impossible to give an absolute answer to these questions. I think you need to consider what type of treatment the patient is on, and then why are they on that treatment. So someone with a lot of active myeloma in treatment, it's probably not the right time to hold any of the treatment to give the third COVID vaccine, or even some of the first 2. I think we understand a little better now that daratumumab and dexamethasone, if those can be held, patients might have a better vaccine response. But again, it is so dependent on who the person is, what the treatment they're on, and what the status of their myeloma is.
Okay, I think that handled about 5 questions for COVID. Let's go to something else here. Do all MM diagnoses show an M spike? If no, what test is used ongoing as the go-to to show progression and activity?
So I'm trying to 15% of myeloma patients their plasma cells will be so mutated that it'll forget how to make the whole antibody that Dr. Cowan had mentioned, and will only produce the light chains. And then the remainder of patients will produce, and the best test for those light chain producing patients is the serum free light chain analysis, which is just revolutionized, how we used to do things, because everybody used to do 24-hour urines prior to the light chain test coming out. Every blue moon, sometimes we're stuck with having to use the 24-hour urine Binge-Jones protein test to measure light chain patients. And then there are the remainder of the patients that will produce a heavy chain, an IgG, IgA, rarely IgM or IgD. And for that, the SPEP, the serum protein electrophoresis, can define the disease. And the higher the number of plasma cells in the marrow, the higher those light chains are in protein. As you do treatment, the number of plasma cells fall, and so those proteins fall. 1% of patients will produce nothing at all. They'll be asecretory. That sometimes you can pick up something on that mass spec test we talked about. I think Dr. Cowan had mentioned sometimes we can use PET scans and other indirect measurements to see how those patients, how their disease is going. But I think the toughest kind of measurement of disease are the patients that have asecretory myeloma.
And with that, we'll end this question and answering segment. All right, all you people out there in webinar land, put your pencil down and do a hand clap. Thank you, Andrew. That was fantastic. thanks, Craig and Mary, for getting a question in there too. And it's going to happen right now with Dr. Cole. Craig and I go back about, I don't know, Craig, 10 years, something like that. And I met Craig when he was a baby at Michigan State University. So Craig, if you're on, take it away with your slides. Thank you.
I don't know. I think my wife may still say I'm a baby. But thanks, Colleen. And thanks for the intro, and thanks definitely for the invitation. And so I am going to talk about, let me just settle my screen a bit, about relapsed myeloma. There we go. We'll talk about relapsed myeloma, treating relapsed myeloma, some of the tools of the trade, the antibodies that we use to treat. And then I'll talk about the new stuff. And there is so much excitement around the new therapies for multiple myeloma. And I was just at the International Myeloma Workshop, and the big highlights of that therapy were the antibody drug conjugates, CAR T, and BiTE antibodies. And I'll explain how those work and kind of the results in what the new stuff is doing. Then we'll talk about clinical trials. And so, question that patients a lot of time will ask me is exactly what is myeloma? And it's when the cancer returns after received some type of treatment. Usually there's a period of remission or response, and when the disease comes back, people will use the terms relapse, recurrent, or progressive kind of interchangeably. And because myeloma doesn't have a cure yet, it is likely that patient at some point will have relapsed or recurrent or progressive disease during their course. The good thing is that with therapy, relapsed myeloma patients can achieve a second response and third and fourth responses. However, when the disease becomes refractory is when it's not responsive to therapy. And a term that you'll see used quite a bit is RRMM, which stands for relapse refractory myeloma. And we will group relapse patients kind of in that category, especially when we talk about some of the clinical trials. So that's a term that I wanted to make sure everyone understood. So the typical course of a patient has myeloma is that patients will have a lot of disease burden, or their M protein or the light chains will be very high at the time of diagnosis. They start an induction therapy like Dr. Cowan had mentioned earlier, and then they may receive a stem cell transplant. Then there'll be a maintenance therapy. Hopefully that will last for 5 years, 6 years, where there'll be a maintenance therapy and the disease will be at bay. And we call that a remission or a plateau of the disease. And that is the first line of therapy, induction therapy, transplant, and maintenance. At some point, the disease, the M protein will start to go up. And we call that a biochemical progression or biochemical relapse. And that's when the M protein has gone up by 25% from its lower point, or the M protein goes up by 0.5 from its lower point, or the light chains will increase by 10 milligrams from its lowest point. We don't treat when patients usually when they have a biochemical progression of disease. Usually we watch them very carefully. And if the number is doubling or if it's rapidly progressing, then we'll consider treatment. That is, again, we call progressive relapse. A disease. And we try to, just like Dr. Cowan had mentioned earlier, we try to catch the disease before patients will develop those CRAB criteria, the hypercalcemia, renal insufficiency, anemia, bone disease. So then we start the second treatment before they develop symptoms, hopefully. And they go into a second remission. And hopefully that lasts a long time. And we continue that therapy that got them in that second response. And that's the second line of therapy. We continue that, and hopefully that will be a long time. And then when the disease relapses, we kind of repeat. The protein goes up, we treat it again, it goes down, then it goes up again, and it goes down again. Those are third, fourth, and fifth lines of treatment. And hopefully that's a long. But at some point, the disease will relapse. We start a therapy and it won't respond. And that's what we call refractory disease. And that's where the hammer of science in clinical trials, the pointy end of the science, can push, as we're looking to push down that refractory disease and then have patients live longer. Again, when patients have relapse, most patients will have biochemical relapse of disease. However, some patients have symptomatic relapses, and a lot of those symptomatic relapses will be with lytic bone disease. And that's why it's important if patients have biochemical relapses that they get a PET scan to make sure, we observe patients that have biochemical relapses, but also we want to make sure it's not a symptomatic relapse. And a PET scan will help us be able to ascertain that. Because if someone has active lytic bone disease, that's a reason to start treatment right away. Again, like Dr. Cowan had mentioned, in the past 6 years, there have been an incredible number of therapies and novel drugs that have been approved by the FDA. This is a partial list in the past 6 years of drugs approved by the FDA. 30 new drugs approved by the FDA, with 14 new agents. That is well above all the other cancers that are out there. Myeloma research has come such a long way in a very short period of time, where now we have lots of options to treat patients with relapsed myeloma. And so the trick is which patients need which of those therapies when they relapse. And part of it is based on is disease related. How quickly is the disease relapsing? Is it relapsing kind of slowly, kind of how the disease started, or is it relapsing quickly, unlike how the disease started? Do patients have crab symptoms like kidney disease that we need to treat quickly? What is the duration of their last therapy? Was it years and years since their diagnosis, or is it only a couple years since their diagnosis? And then we look at if a patient has high-risk relapse, where the disease kinetics are very rapid. That may be indicative of high lactate dehydrogenase, or LDH. Do they have extramedullary myeloma, which is high risk, where the myeloma is now occurring outside the bone and bone marrow? And do they have any of those high-risk cytogenetics on FISH, like Dr. Cowan had mentioned, at the time of relapse, or secondary mutations like RAS mutations, MYC mutations, or P53 mutations would be high risk. Then we take a look at the patient. How old is the patient at the time of diagnosis? What is their level of activity, their performance status? Do they have side effects from the last therapy that they had, like ongoing neuropathy, low blood counts, or kidney impairment? And have they had any side effects of therapy, like having blood clots? And that will all influence the regimen that we use. And then regimen related. What are their previous lines of therapy? Were they relapsing on or off maintenance therapy? Previous drug exposure? And how much time has occurred since their last transplant? Because if the transplant lasts a long time, if they had 6 or 7 years that they're in a remission after transplant, we may consider transplant again. But the important thing is we look at all those things. So every myeloma patient is different. That's why we call it multiple myelomas, that every patient is different. And every patient, we weigh different things. And of course, the most important thing is patient preference. You have so many options now that I usually write down all the options for relapsed myeloma with my patients, and we decide what works best for their goals and their lifestyle. So when patients relapse, again, there are lots of different options, and most patients will be on Rev maintenance. And And there are a lot of different therapies to pick when patients have their first relapse on Revlimid maintenance. But the biggest thing is not to repeat the Rev over again. We try to stay away from Rev if someone's relapsing on Revlimid. And you'll see these are some of the regimens that we use. And I don't have Revlimid listed. And so we kind of try to shy away from the class of drugs, even though Pomalyst is a good drug to use at relapse for when patients on Rev maintenance. If patients were on Velcade maintenance, again, we try to stay away from Velcade or Nenlaro, which is an oral version of Velcade. And again, some of the regimens listed that are options for those patients. And if the patient wasn't on any maintenance, then we can pick any of the above in first relapse. Our preference, though, and I always talk to patients, is about clinical trials. If on their second relapse, again, the playbook is really open. It's important to know what they relapsed on after on their second relapse. Again, lots of different options there. One at the very bottom, Darzalex Faspro, which is daratumumab that can now be given under the skin, it is way easier, way quicker, way safer than using intravenous daratumumab. And really, when I mention Dara in any of these slides, I really mean the use of subcutaneous Dara. But the playbook is open, and if we're at second relapse, at more advanced or aggressive disease, and after several prior lines of therapy, then we have the selinexors, the Blenreps that I'll mention, the melflufen and CAR-T that I'll mention. Still, patients will get allogeneic stem cell transplants or donor transplants at the time of relapse. But again, our big tool that we use is clinical trials during relapse, because that really is the cutting edge therapy in multiple myeloma at this time. So before I kind of launch into some of the data, it's good to sort of level the playing field. Again, another football analogy. And what we're going to talk about is, well, how well did any particular therapy work? And a complete response is when basically we do the lab work and we don't see a monoclonal protein, where a very good partial response is when a 90% reduction, partial response is 50%. And I think Kelly has seen my actually Dr. Sagar-Loniel's iceberg model of disease, that at diagnosis and at the time of relapse, the M protein can be very high, and at 50% for partial response, no protein, a complete response. And then we will have some discussion of MRD where the M protein is 0, but there still may not be some residual disease left over. And then how long does a therapy work? OS means overall survival from the time of relapse that we'll mention with trials. Progression-free survival, very important term. How long did that particular treatment work? And AE means adverse events or side effects from any particular therapy. So let's talk about some of the data. We'll talk about the immune therapies, really the super exciting subject of and our new main tool in treating multiple relapse myeloma. So this is a plasma cell, and plasma cells have proteins on them that identify themselves as plasma cells, and especially myeloma cells. They have CD38, CD138, CD40, and SLAM7, and that helps your body identify plasma cells from other cells. What we've done is that we have built antibodies. So antibodies will attack viruses, bacteria, and rid them from the body. Antibodies, of course, when patients have myeloma, they're not making antibodies to their myeloma, or else they wouldn't have myeloma. So we've built antibodies against myeloma in order for the body to naturally clear them as it would any infection. For CD38, we have daratumumab and isatuximab. For SLAM7, we have elotuzumab. They're investigational antibodies against the other surface proteins. But BCMA, B-cell maturation antigen, has really become one of the top targets for myeloma, to identify those myeloma cells from the other cells in your body. And when they've looked at the number of BCMA molecules on top of lots of different cells in the body, definitely plasmacytoma and myeloma cells have the most BCMA, which makes it an excellent target to go after, to identify those myeloma cells and kill it. This is another slide which talks about a lot of different therapies that are immune-based to go after the myeloma cell. Those monoclonal antibodies we'll talk about in a second, the bispecific antibodies and bispecific T-cell engagers that we'll talk about, but also some of the natural killer cells, off-the-shelf CAR T, checkpoint inhibitors, all super exciting modalities of therapy. So how do these antibodies work? Well, there's a myeloma cell, and there are those surface proteins that we talked about, either SLAM7 or CD38. And we administer daratumumab, elotuzumab, isatuximab, those manufactured anti-myeloma antibodies. They'll stick directly to the myeloma cells, and then your good guy immune cells will come in. Anything that has an antibody attached to it, they'll recognize and destroy them. They'll shoot granules or pellets or bullets towards those myeloma cells and kill them. Also, when antibodies are attached to anything, including plasma cells, the good guy macrophages and T cells will directly in hand-to-hand combat engage those myeloma cells and kill them. Also, when antibodies are attached to anything, and plasma cells included, myeloma cells included, an ancient part of our immune system called complement will assemble a protein complex and bore holes inside the cell, killing them, having them bleed to death. I don't mean to be so graphic. And antibodies, when they attach to myeloma cells, will actually cross-link and short-circuit the myeloma cells and kill them. And then the final mode of activity, actually, the final is another one on top of this that I can't figure out how to animate. But another way is that the antibodies will attach to myeloma cells. Myeloma cells need to be attached to bone marrow stromal cells in order to grow and proliferate. But the bone marrow stromal cells will kick the myeloma cells off of them if they have an antibody attached to it. So you have all those modalities of action against the myeloma cell by having antibodies attached to it, which is why the antibody therapies have been so successful. Or we have the elotuzumab or Implicity that is approved for relapse refractory myeloma. It's IV and it's given every week for 8 weeks and every 2 weeks. We have daratumumab that's either IV or sub-Q. Again, we're using a lot of sub-Q daratumumab these days, and that is approved for newly diagnosed myeloma in patients who are eligible for stem cell transplant in the combination of Velcade, thalidomide, and dexamethasone. Lots of new data in using Revlimid, using RVD, Dara for newly diagnosed myeloma, and it's one of our main agents for relapse refractory myeloma. And then ixatuximab, again approved in combination with Pomalyst and Kyprolis for relapse refractory myeloma. And then I'll talk about one of the new modalities of therapy, the antibody drug conjugates, in a second. So for Dara, the Dara data, and this is actually fairly old because we've been using Dara for at least 6 years now. Dara combined with Rev, excellent response rates after one prior line of therapy. Dara Velcade, good response rates. Dara Pom and Dara Kyprolis, again, excellent response rates. And some of the key side effects could be low counts and infections. So make sure you tell your doctor if you have a cough or fever. And it used to be infusion reactions, but now that we're giving Dara sub-Q, those infusion reactions are much less. With elotuzumab, again, excellent responses. Even though I would say Dara is probably our #1 go-to in first relapse, but I think people forget about elotuzumab. Very good agent to use in second relapses, third relapses, again, with very good response rates also. So let's talk about some of the new stuff, some of the second generation antibodies, and that would be the antibody drug conjugates. So how do they work? Well, here's an antibody, like I had mentioned, except this antibody has a chemotherapy attached attached to it. So this is like a Trojan horse, that there's a chemotherapy agent that's attached to the antibody via a linker. And when this antibody goes after the myeloma cell, it does something very different, is that it attaches to BCMA, and then that antibody is incorporated into the cell, bringing that Trojan horse chemotherapy only to the myeloma cells. So that chemotherapy doesn't circulate through your body like other chemotherapies would do. It goes directly to the myeloma cells. The antibody then unloads its payload and kills the cell. In the process of killing the cell, it releases chemicals that actually attracts those good guy killer cells to go attack the myeloma cell. So you got a 2-4, you got actually a 3-4 mode of action, in that it kills the myeloma cells from inside, and then the T cells and macrophages will kill it from the outside. Incredible response rates, very good response rates. This drug is called belantamab mafodotin, or Blenrep. And again, and the chemotherapy is osteristin. I pronounced that wrong. And the DREAM2 trial looked at giving Blenrep 2.5 milligrams every 3 weeks with great responses, and that being approved by the FDA and the European agency in August of 2020 for patients that had more than 4 prior lines of therapy, including DARA, a proteasome inhibitor, and an IMiD. The biggest side effect had been the eye toxicity, or keratopathy, disease of the cornea, or changes in visual acuity, other ocular symptoms. And so before each dose, each patient requires an eye exam for the REMS program, or the risk evaluation mitigation strategy, to make sure that patients don't have some early eye symptoms before they receive their next dose. But when you look at the responses on that DREAM2 study, again, about a 30 to 40% response rate for all patients, and even in extensive prior lines of therapy, very good response rates. And the duration of the response, so the progression-free survival, again, on the order of 13 months and 11 months for prior lines of therapy, overall about 11 months, a duration of response. Really good duration of response. Again, it's those eye symptoms, the keratopathy, that we really have to watch for. And usually when patients develop have an abnormal eye exam, then we'll hold the Blenrep. And the very interesting thing about holding Blenrep is that Blenrep can be held for several cycles, and patients will maintain their response to therapy. Thrombocytopenia is also the side effect. And to disturb vision, most patients will go to their baseline eye findings and eye exam with holding therapy and then restarting therapy. Then there's a DREAM6 study. So if a Blenrep works good by itself, how about combining with other therapies? And in this, it was combined with Velcade. We had this trial at Michigan State. It's now, I think, closing in November. But this, it combined with Velcade, again, we got those responses from 30 to almost 80%. And the duration of response hasn't been met yet. So we're still waiting for some of these patients to relapse. But again, very good responses. This has also been combined with Pomalyst with 80% response rate. The big thing with it, again, is the eye exam, that we have to really watch for that keratopathy or corneal disease. So let's talk about CAR T. And so there are the B cells, which attack outside invaders, and then are the T cells that attack viruses and misbehaving cells. So this is, get it, CAR T. I'm in Detroit, so that's a Model T car. There's Mr. T in a car, CAR T. I still think that's hilarious. And then this is the real CAR T. Those cytotoxic T cells killing cancer cells. So how does that work? Well, we're going to talk about CARs, the chimeric antigen receptors that help T cells find those cancer cells. And if we can program your T cells to recognize the cancer cells, we can use your T cells to kill the cells. So how does that work? Well, patients get their T cells pherese in the same way that they pherese off the stem cells for stem cell transplant. So we obtain those stem cells from your body, and then we get a man-made or chemical or research-made virus that contains a CAR gene, a gene that can recognize cancer cells. And in the laboratory, we infect your T cells with the CAR gene, and that CAR gene then gets inserted into your T cells. And then their T cells will read that DNA that was inside that virus that is now inside your T cells, and it will create a antigen, a chimeric receptor antigen that will hunt down cancer cells. So now you have a cancer hunting T cells that are then grown into the millions and millions, and then infused back into your body, and then those T cells go hunting cancer. And so a simple thing is a T cell gets a retroviral vector and turns a normal, happy-go-lucky T cell into a cancer-killing T cell. Again, we use the BCMA, the B cell maturation antigen to recognize those cancer cells. And again, we transfect your T cells so that they go hunting anything that has BCMA attached to it. And then those are, in about 14 days or a month, those are grown, infused, and then hopefully that last little bit is those cells will actually reproduce in your body, creating an ongoing therapy to treat the myeloma. And again, those T cells engage the myeloma cells via those the BCMA receptor, again, only found on those plasma cells. The big toxicity of CAR T is cytokine release syndrome, which is a severe inflammatory reaction related to T cell engagement. So when those T cells are super angry with CAR T, when they find those myeloma cells, they will release lots of chemicals and cytokines, kind of flu, severe flu-like symptoms that are called the cytokine release syndrome. They can be mild, grade 1, or they can be really severe, grade 4. And grade 4 can cause a multi-system organ failure. There's also a neurotoxicity associated with it. So there's standard cytokine release syndrome, which can cause pulmonary edema or the lungs filling up with fluid, high fevers, fatigue, headache, or low blood pressure. And the neurotoxicity, we're still trying to understand, can cause confusion and word finding difficulty, and sometimes encephalopathy. And so so those are some of the side effects that I'll mention with CAR T. Ide-cel was the first CAR T approved via the KARMA study, where they got those T cells from the patient. Patients who receive CAR T usually uniformly need to receive chemotherapy, sort of getting rid of some of the other normal T cells so that the CAR Ts have an unopposed view at killing those myeloma cells. And in the KARMA trial, they're given at different dosing to see what's the best dose to use CAR T at. And at 128 patients with a median age of 61, a lot of those patients had high-risk cytogenetics. Manufacturing the CAR T was successful most of the time, and it took about 10 to 14 days to get the T cells in, and basically takes about 3 weeks to a month, at least in our hands, to get from pheresis to CAR T. The overall response rate, outstanding for these high-risk, highly treated patients. And I think that you can see that a lot of those responses, 81% were at the higher dose of the ide-cel. And again, outstanding response rates. The one thing that sort of got our attention is that the duration of response, that it was about 11 months, not unlike what we saw with the blend route for the median duration of response. And the higher the number of T cells of CAR Ts given, the longer the PFS at 12.2 months for the higher dose and really the moving forward dose with CAR T. When you look at cytokine release, a lot of patients with cytokine release syndrome, the vast majority of those were mild grade 1. And we have very good therapies for cytokine release syndrome. With neurotoxicity, again, the vast majority were grade 1, not those really severe neurotoxicity. And it was primarily confusion that was transient. So again, ide-cel was approved by the FDA based on the KARMA trial. And again, it is after several prior lines of therapy. And again, the PFS was about 11 months. For patients on CAR T, the one thing about a CAR T is that it has been a bit of a delay in getting all the patients that need to be treated with CAR T due to manufacturing problems. This slide shows busy slide shows a lot of the trials that are going on. This is a really incomplete list of all the CAR T trials that are going on right now. The CARTITUDE or the Citracel is probably the next up to be approved by the FDA based on really good responses. Again, in all these CAR T trials, lots of prior therapy. The CRS, again, a lot of patients had cytokine release syndrome. Very few had the severe cytokine release syndrome. And again, when you look at these overall responses for these really, 6, 7 prior lines of therapy, outstanding overall responses, and a lot of those were better than a VGPR 90% reduction, including a lot of MRD negative patients, and which is unprecedented for this group of patients. What we need to really work on is having these therapies last longer. And again, the CARTITUDE trial, we're still waiting to see how long those responses last, but they appear to be a bit longer than with the ide-cel. So let's talk about the bispecific antibodies. So this is the other alternative to, again, probably the 4th generation antibodies. So I mentioned that we have those anti-BCMA antibodies are at the bottom in brown with the business end, the sticky end that sticks to the BCMA at the top. Those are the brown parts of the antibody. We also have antibodies against T cells at the top of the screen. And I've made those kind of grayish. Well, what if you can get the sticky end from the T cell antibody and from the monoclonal antibody? Like the sticky end to the T cell, the sticky end to the myeloma part, the BCMA part, and you combine it into an engager. Or what if you can build an antibody that will stick to both T cells and myeloma cells via CD3 and BCMA? Well, that is a bispecific antibody or a bispecific T cell engager, where you have 2 single chain antibodies bound to each other. And what that does is it will bring the T cell to the myeloma cell, very similar to what the CAR T will do. It brings that T cell that otherwise wasn't sure what to kill and engages it right to the myeloma cell, where it will get activated and then begin to unload its cancer killing payload directly to the cell, very similar to what happens with CAR T. Erlantamab is one of the bispecific antibodies that we're really excited about against BCMA and CD3 on T cells. There was a phase 1 trial which increased the dose slowly to see what the responses and what the safety was for erlantamab. And what was really, really remarkable is that at the high dose during the phase 1 trial, 83% overall responses, again, with 50% of those being VGPRs and 16 being CRs, for a heavily pretreated group, very similar to what we're treating with CAR T. The trick about this is that it is given on a weekly basis, opposed to CAR T being kind of a one and done. But the BCMAs don't require chemotherapy to be given prior to infusion. And again, excellent response rates with this therapy. Again, there's some cytokine release syndrome, and we're looking to see what the durability of response is. Lots of different trials going on with with the T cell and bispecific engagers. Again, across the board, very impressive response rates for these heavily pretreated patients. This was a slide that was at the IMW that Gareth Morgan had showed, just showing you a lot of the things that are going on in phase 1, 2, and 3 trials. The research is hot and moving very quickly with a lot of new agents, including molecular-based agents to treat myeloma. And so with that, I'll segue into clinical trials, because everything I showed you is based on clinical trials, what patients have done to bring forward the disease, to have us cure myeloma. Clinical trials do save lives. So phase 1, this is kind of the outline of clinical trials. Phase 1, few patients involved, and we increase the dose slowly of the investigational drugs. And at the bottom, in order to even start doing a phase 1, the FDA has to approve the safety of that drug. So it's not that we get a drug from the lab and then just give it to patients. It goes through an entire process assuring the safety of it through the FDA before you can even administer to a patient. So already there is a level of safety in a phase 1 trial. It really is, what's the best dose and what side effects are we seeing with it? Then the phase 2, we give it to more patients, again, checking the safety and dosing. And the phase 3s, we can compare it to the best available therapy at the time. Is my therapy better than the previous therapy that is a standard of care? Then it goes for FDA review, and then it gets approved. When we've asked myeloma patients specifically, what has you hesitate about clinical trials? The biggest thing, the top 2 results that we got were patients being uncomfortable with being randomized, fear for receiving a placebo, fear of side effects. I should mention most places, their health insurance will approve clinical trials. Of course, that's really based on your insurance and the region that you live in. And we'll talk a bit about clinical trials in my community. So what are the big myths? One myth is that if I enter a clinical trial, there's a good chance I'll receive a placebo. That's a myth. In cancer clinical trials, you can't give placebos. We have to give the best available therapy versus the new therapy. But in cancer medicine, there are no placebos given unless the standard of care is observation. But with myeloma, with multiple active myeloma, no placebo trials. You either get the best available therapy at that time, or you receive the best available therapy at that time, plus the investigational drug. If my doctor doesn't mention clinical trials, it must not be right with me, or right for me. No. Your doctor may not be aware of the clinical trial. Dr. Cowan had mentioned how important it is to see a myeloma specialist because, gosh, with the primary oncologist with so many different cancers, so many different clinical trials, they may be unaware of a clinical trial. If I enter a clinical trial, I'll be a guinea pig. That is absolutely false. The clinical trials provide the best care that's currently available, and possibly a new therapy. There are no, especially in myeloma, how competitive myeloma clinical trials are these days. There are no guinea pigs. And again, the FDA has to approve before we give any drugs to any patients that are investigational. And so when we started out, years, decades ago, the therapies that we had were bad. They had bad side effects, and they had poor responses. Why? And that's why, like Dr. Cowan had mentioned, patients only lived a couple of years. The goal is to have little to no side effects and have great efficacy, the effectiveness being great. So we started out with early clinical trials in the 60s with melphalan and prednisone. That became the standard of care. And then as we did clinical trials, we found that Revlimid was a great drug to use for upfront therapy for myeloma. That became standard of care. And as we've done more clinical trials, we've increased the number of side effects and increased the efficacy. And it is inevitable that the standard of care, patients are climbing that ladder. And it is inevitable that as we improve, we get rid of the side effects and make the therapies more effective, that we will cure multiple myeloma. It is, and I think that the tools we're on the edge of having that, but we need patients to help us with that, to be involved in clinical trials. How to find clinical trials? If you go to the IMF website, and you go to what is myeloma, there's a line there, a link that says clinical trials. You'll click on that, and it will take you to what a clinical trial is. You go to the search myeloma matrix, and you hit that button. In the myeloma matrix, you can pick where you are, if you're newly diagnosed, smoldering, maintenance therapy, or relapse, and then we'll find a clinical trial as a phase 1, phase 2, or phase 3 in your area. If ever in doubt, you can go to cancer.gov, at the NIH, their website, and there's a purple box or a purple circle that will follow you all over that website. You can't get rid of it. You click on that, you put in multiple myeloma, it'll take you to a clinical trial. So I hope I've conveyed some of the excitement that we have on these incredible new therapies and the incredible work. And I greatly thank the IMF for inviting me, but most of all, I thank the patients that have been involved in clinical trials that have given us these results that I can share with you today. And there's my email address if there are any questions. So thank you very much.
Okay, we have a lot of questions, but I want to keep on time here and save it for the panel at the end. Craig, as usual, I love the last slide where you showed the steps for myeloma. It's fantastic. Your presentation covered a lot of the meat and potatoes of myeloma, what's coming up and such. So for those of you on here, remember, we'll get a recast of this and you can get some more of your answers, as it were, because this was an intense talk. It was a lot of things. Both these talks aren't just your run-of-the-mill, how do you do, everything like that. These are really comprehensive communications for the myeloma patients. So with further ado, I'd like to introduce Mary Steinbach from the Nurse Leadership Board. She's at the Hutchinson Cancer Institute in Salt Lake City, where she says it's raining where she is. So maybe that will turn into snow sometime and you'll get to go skiing.
Yes, that's always the goal around here.
Thanks, Mary.
Thank you, Kelly. It's a real honor for me to be a part of this workshop today with all of you. I have the privilege to speak to you about how to manage symptoms related to multiple myeloma, side effects of the multiple medications we use. We've just had two wonderful talks from Dr. Cowan and Dr. Cole that touched on a lot of these medications and symptoms that patients have. So we'll just jump right in. Next slide. So most of us know multiple myeloma itself comes with a constellation of symptoms, as do the medications that we use to treat the disease. And sometimes it's difficult to tease it out, what's causing patients what. So often at diagnosis, patients experience fatigue. They may have an anemia, pain related to fractures or bone lesions. And then once we start treatment, patients can still experience pain, fatigue can be increased. Peripheral neuropathy is a common side effect of some of the medications that we use. Dr. Cowan spoke to shingles, and often patients who have multiple myeloma long before we recognize the disease do have frequent infections. And then again, the drugs we use can cause those infections. So it's really important to understand how you feel at diagnosis and then throughout your treatment course, and then always be speaking with your providers about the side effects of the medications we use. Next slide. So over the next few slides, we'll just touch on most of the FDA approved medications that we use for treating patients with myeloma. A lot of them have a similar side effect profile. So I would say this myelosuppression category, where patients can experience low white blood cell count, low platelet count, low red blood cell count, so anemia, neutropenia, thrombocytopenia. That's really a side effect across the board with all the multiple myeloma drugs. The potential for peripheral neuropathy exists with the proteasome inhibitors, along with some of the IMiDs, particularly thalidomide. That's not a drug we really speak too much at all anymore, but it is still used in Europe, and sometimes in salvage treatments. And then there are some cardiotoxicities or heart side effects that are associated with some of the drugs we use. And the GI side effects can include diarrhea, constipation, nausea, and vomiting. And sometimes a lot of these medications, for instance, Revlimid is pretty well known to cause diarrhea for some people and constipation for others. So it's about figuring out what's happening to you as the patient and then how we can help you with those side effects. Next slide. So this speaks to the monoclonal antibodies and then our antibody drug conjugates, the HDAC inhibitors, which includes this drug known as panobinostat, and then Xpovio. And again, the side effects on most of these medications are pretty similar. Next slide. And then kind of our last bulk of myeloma drugs, some of these being the newer ones. You see CAR-T here on the far side, and we have cytokine release syndrome, which Dr. Cole just spoke about as one of the major side effects. But again, I think we're going to end up seeing as we use these medications, these newer meds more and more, that they probably have some other side effects associated with them too. The alkylating agents, so kind of our conventional chemotherapy that we use is pretty well known for sometimes, well, for infections that come along with low blood cell counts. There are, again, heart side effects and then these GI disturbances. Next slide. So steroids, Dr. Cowan mentioned that sometimes this is the least tolerable medication that we use, and it is really important. The dexamethasone is the most common steroid that we use for multiple myeloma. It is very important up front. It does kill myeloma cells and it helps a lot of the drugs we use work better. But over time and throughout the course of treatment, steroid doses can be reduced. And so I think a lot of times patients and even providers get stuck in this cycle of using higher doses of steroids and maybe not fully understanding what a patient's side effects are from them. So it's important to speak up to your providers about what you're experiencing as a side effect of the steroids. You see listed around this person that irritability is a common one, sometimes blurred vision, bloating, difficulty sleeping, weight gain, hair loss. So these are things that affect people on a daily basis. And certainly around the dosing of the dexamethasone, whether it's twice a week or once a week. So please speak up if you're experiencing any of these. There are some things we can do to help manage it. So depending on how you take your dexamethasone and when you take it may help to manage some of the side effects. Taking steroids with food is helpful. And then again, sometimes patients need other supportive meds to help with the side effects that can come from the dexamethasone. I think more recently, we're doing a better job in the relapse refractory setting of perhaps starting with lower steroid doses and then getting patients off of steroids as soon as possible. And certainly some of the newer class of medications that Dr. Cole spoke to, we can even use them without any steroids, and that's a good thing for patients. Next slide. Fatigue, depression, and anxiety are very common symptoms for all patients with cancer, particularly for multiple myeloma patients. It's important to recognize, and this was shocking to me even to read, 70% of patients experience fatigue, but only 20% tell their providers. And so again, this plays into, perhaps as you're newly diagnosed, you have a lot of fatigue associated with the amount of multiple myeloma. And perhaps that gets better through induction treatment as some of your disease-related symptoms improve. But it can come back certainly through the transplant period, certainly while on maintenance therapy and long-term maintenance. As Dr. Cowan mentioned, some side effects can pop up even when you've been on a medication for a very long time. I think the recent COVID pandemic has perhaps helped us all realize how important topics such as fatigue, depression, and anxiety are. They certainly affect patients' quality of life. And there are a lot of things to do to manage them. And I think most importantly, a lot of the management can be non-medication based. So we know that exercise can make a good difference. Proper sleep and being well rested can make a good difference. Having social support is super helpful. And that's why things like these community workshops are so important. Meditation and prayer are helpful for some. And then there are medications that in certain circumstances should be used and certainly are very helpful. Next slide. Infection prevention and treatment. So infection is a risk of having multiple myeloma. And then again, with treatment, you may be at a higher risk for some infections. So common sense things to keep yourself healthy and infection free is good hand washing. Nowadays, certainly wearing a mask is a very important component to this. Avoiding crowds at certain points during your treatment, perhaps if you're neutropenic or going through stem cell transplant. Being up to date on immunizations is a big recommendation of ours. Taking antibiotics or antiviral medications, depending on what treatments you're on, is also certainly important. And then again, understanding what symptoms from infection might be, upper respiratory symptoms such as congestion, cough, having a fever, being dizzy or feeling short of breath. Those are certainly all things you should be speaking to your healthcare team about. Next slide. DVTs, so a deep vein thrombosis and pulmonary embolism. These describe a blood clot. And so very often for patients with any type of cancer, but particularly multiple myeloma, you're at risk for developing blood clots. Some of the medications we use for the treatment of myeloma can increase this risk. And so this is a symptom to be aware of. Often the symptoms of a DVT are warmth or redness in an extremity. They often happen in the lower extremities. So in your legs, having a swollen leg that is red and warm is something you need to report to your healthcare team. Symptoms of a pulmonary embolus, so that's a blood clot in your lung, that is going to be shortness of breath, perhaps chest pain, feeling your heart rate go up as you stand up and walk. These are things to be aware of. We will often put patients on medications to help prevent things like DVTs and PEs, depending on certain risk factors with the rest of the medications that you're on. Next slide. GI symptoms, as I discussed, a lot of times the meds we use can either cause diarrhea or constipation, and it really is patient dependent. So whenever I meet a new patient and we're starting a treatment, I like to establish kind of what their regular bowel regimen is. Are you someone who it's typical to go to the bathroom every day, or is it every couple of days? Do you have nausea in your life otherwise? And then just understanding what the potential are from the meds we're starting. There are lots of medications that are out there to use for diarrhea or even constipation. And then again, there's a lot of medications we use that cause some of these things. Nausea is something that happens pretty frequently through the autologous stem cell transplant phase for patients. And there's certainly very good medications we can use to help with that. Eating a well-balanced diet is really helpful for your GI system. And you'll just see here like a long list of medications for some of these side effects. It's important to maintain a healthy weight and be able to exercise and have stamina through all of your treatments. And so controlling GI symptoms is a good part of this. Next slide. So our kidney function, we talked a little bit earlier today about how changes in kidney function can be part of the diagnostic criteria for multiple myeloma. All myeloma patients are at risk for kidney or renal dysfunction, and this is based on how the disease works and what those light chains can do and get stuck in the kidneys. So Dr. Cowan had mentioned that having a high kappa, or not necessarily kappa, but having a high light chain number is a risk factor for damage to the kidneys. Certain other illnesses that are part of life, comorbidities such as diabetes or hypertension, can cause changes to kidney function. So I think understanding the status of your kidneys and how you can help prevent any further damage is important for patients. On a very simple level, hydration is a good part of this. And I'm always talking to patients about being able to drink about 2 liters a day. And that's just like a goal for having a good hydration status. And then understanding other medications that you take and how they may pose potential risk to your kidneys depending on what you're going through. Oftentimes at diagnosis, patients have poor kidney function. And then once we start treatment, this can be improved upon and you can really regain some of that kidney function back. And then it's just important through the whole course of your multiple myeloma to try to protect your kidney function as much as possible. Next slide. So lytic lesions and bone damage is a big part of multiple myeloma, and this can be with symptoms for patients or without symptoms. 85% of patients with multiple myeloma do have bone disease, and sometimes this ends up being a chronic pain situation for a lot of myeloma patients. Again, I think after we start treatment after initial diagnosis, pain can be improved upon. We certainly have medications such as the bisphosphonates and now Xgeva and denosumab that we can use to help strengthen patients' bones. Good nutrition, weight-bearing activity, taking calcium and vitamin D are all things that are helpful for patients. I think recognizing what your bone status is in terms of burden of lytic lesions, and then if you have pain associated with those, oftentimes we incorporate pain management teams in taking care of our patients, or physical therapy or physical medicine rehab team to help kind of maximize strength in other areas to help support your skeleton is very important. Next slide. Peripheral neuropathy. This is an ongoing long-term symptom for a lot of multiple myeloma patients. I think certainly some patients at diagnosis already have peripheral neuropathy. It is occasionally described as part of the disease process itself, and also can be associated with a component of a plasma cell dyscrasia that's called amyloidosis. And patients can have peripheral neuropathy from other causes at diagnosis. But then we know, and it's described quite well, that Velcade and the proteasome inhibitors are likely to cause peripheral neuropathy. So this is a symptom you're always going to get asked about when you're seeing your myeloma providers, and it's important to describe to them exactly what you're feeling. Everybody sort of perceives peripheral neuropathy in a different way, and there certainly are objective ways that we can measure sense loss in your nerve endings, but I think a lot of patients end up having descriptions that can vary for people. So peripheral neuropathy, when it's induced by medication management or myeloma drugs such as Velcade, we know that reducing Velcade to once a week can make a difference. Holding doses can make a difference. And hopefully with time, this peripheral neuropathy can resolve for patients. But I think this is an important symptom because it can evolve over the course of a myeloma patient's treatment and lifetime. And it's important to consider when choosing medications, especially in the relapse refractory setting, when you may have a couple of drug options. If you're someone who has had peripheral neuropathy previously, then maybe that's going to guide decision-making to a different medication. There are supplements and some topical ointments. There's even some light therapy that's described these days that can help patients with peripheral neuropathy. But again, when it's caused by one of the multiple myeloma drugs, the best things to do are either make a dose reduction or hold the medication. Next slide. Pain prevention and management. So this, again, does play out over the entire course of a multiple myeloma patient's life and treatment, and adequate pain control really helps people to function, have less depression and anxiety, and continue to play a role in their lives and management. So I think pain prevention and management is super important, and peripheral neuropathy can fall under this. So we do have pain medicine that can help patients. A lot of people can be hesitant about using opioids or narcotics regularly for their bone pain. And I frequently am speaking to patients about initially getting pain under control, and that it may not be a lifelong thing that they're taking an opioid. We can use radiation therapy to bone lesions to help with the palliative effects of that pain and improve upon pain. Again, staying functional, exercising can all help with pain too, but it's important to not live with pain silently. Next slide. And that is it. Thank you for your time.
Wow, Mary, that was really good. Thank you. See, I told everyone that's here that this was going to be a big day, and a lot of information's covered. We had the Nurse Leadership Board does a great job on helping you through what you're going through on the side effects. So as I really want you to review this, I want you to get the answers that you're looking for by looking at the questions and the comments. And then I'd like you to just review it at your convenience. Now, we're going to go to some Q&A here. And let's see. Oh, here's a tough one. When is the best time to stop maintenance chemotherapy? Is it over 2 years, 5 years, 10 years, or longer? Do you have algorithms to make this decision? Boy, that's a pretty big question. I think you're muted, Craig, and there we go. Craig, go ahead.
Yeah, I think that that we still, are still grappling with that. That we, still looking to see when's the best time. The story is probably going to be made with MRD and some of the trials that Dr. Cowan had mentioned earlier. The one thing about, and again, the really exciting thing is some of the newer therapies, like CAR T. When patients, after they receive CAR T, they actually aren't on anything right now. That is probably one of our only one and done therapies where we give it and then patients aren't on any therapy. But for kind of right now, for most patients with standard induction therapy or the standard therapies we're using now, the maintenance therapy is until the time of relapse.
I see. Now, the one of the concerns was that a lady had a CAR T treatment a year ago and still is in remission. What treatments are available after that, if any?
I can answer that. I mean, I think, I would investigate clinical trials. Dr. Cole talked about some of the, newer drugs like bispecific antibodies, T-cell engagers. There's new targets, and like GPRC5D. You can retreat with BCMA therapies. We're still learning about that. So those are the areas I've advised, people to consider. There's nothing approved though. There's no best strategy. I think the best strategy is really a clinical trial, but there's nothing like out there that we know, you should do this next. Like this drug is approved. There's nothing yet.
Sure.
And there's a lot of really interesting preclinical data and using some of the molecular drugs like the MEK inhibitors that may be able to resensitize patients to the IMiDs and using some of the JAK inhibitors, or JAK2 inhibitors, and resensitizing people to CD38 antibodies. We didn't even touch on some of the small molecule drugs that are in clinical trials for myeloma. Just like Dr. Cowan had mentioned, the new targets that CAR T and bispecifics, melflufen is another drug. And so, but really clinical trials, again, is the pointy end for patients after CAR T.
Excellent. Here's a question that's interesting to me. If I do BCMA treatment, e.g. clinical trials, CC 93269, can I later do a CAR T treatment?
I mean, I think there's no reason, there's no biologic cancer reason you couldn't. I think what we don't know yet is, for example, if you wanted to do that study and then you wanted to get commercial CAR T, like FDA approved CAR T, right now it's just a Beckma, maybe soon we'll have cilta-cel. We don't know how insurers will look at that. Our experience with CD19 CAR T cells is that insurers have been pretty strict with looking at, for example, the approved, getting an insurer to cover Yescarta, for example. They used to look at it and if you had a prior CAR T, they would decline it. We would have to try to appeal that. So that's the wild card here. I wouldn't use that as a reason not to do a study. Like if you can get on a study like that, I would, in my opinion, that would be the way to go, because right now you can't get CAR T. Like if you said you wanted to do it today, you couldn't. You would have to wait. I'm not even sure that it's fair to even say 6 to 9 months. We just don't know. So I think you have to go with the best option at hand, knowing that CAR T is challenging right now.
Craig, do you have a comment, Craig?
The good thing is that a lot of the new clinical trials that are coming out are allowing, patients that have had prior BCMA directed agents. And so they're allowing patients on trial that have had things like Blenrep, and saying that it's okay to have prior BCMA directed therapy. And I'm sure with the commercialization of the BCMA CAR Ts, that future clinical trials will also allow that.
Okay, there's going to be 2 questions for Mary here. Are you ready, Mary?
Yeah,
Okay.
ready.
Is it possible to release your neuropathy under acupuncture? My spouse carried myeloma. It is? Okay, great. My spouse carried myeloma on her pancreas under VRD and had acupuncture for a year, then VRD another year, and Velcade maintenance over the past 5 years, and she stopped in 2018. Her main thing was about acupuncture. Take it away, Mary.
Okay, I think acupuncture certainly helps a lot of people with a lot of symptoms that they have. It can help with chronic pain, it can help with nausea, it can help with peripheral neuropathy, certainly. So I think it's something, if you have the ability to seek it out, it's definitely worth seeking out. I'm not sure I understand the relation to the pancreas, other than that it seems like acupuncture really helped this patient along with them receiving VRD. Did I miss a portion of that?
No, that sounds about right. I think the main thing was about acupuncture. So you got it. And I've heard that does work with some patients. Here's another one. Do you have any recommendations for alleviating bone and muscle pain? I take extra strength Tylenol every morning, and I'm curious if there are alternatives to Tylenol.
So I think for a lot of multiple myeloma patients, and really as a general statement, we ask people to avoid the NSAIDs, so the non-steroidal anti-inflammatory drugs, such as Aleve or ibuprofen, because of the risk for kidney damage. Those can be really helpful, though, for bone and muscle pain. So depending on kind of what your kidney status is, it may be okay to take a dose every once in a while. So that's something to speak to your provider about. Extra strength Tylenol regularly can be very helpful. And then think like functional movement. So stretching, a light yoga class, continuing to use your body and move it is also very helpful for pain like that.
Oh, that's good to know. Let's see. Have there been any studies showing better outcomes from SCT based on the time of year they were done? For example, is it preferable to do it in the summer versus winter? Also in terms of recovery and complications, time of year. Does that make a difference?
I'm not aware of any studies that show a difference. I think probably what reading between the lines, I think, at least what I've discussed with patients, concerns are surrounding respiratory viral illnesses that are more common. Supposedly, we think of them as being more common in the winter, but the reality is, before COVID, there was always, respiratory viral season in the summer, and then there was respiratory viruses in the winter. And, in my experience, they're an issue all year in transplant patients. The most common illnesses we see, at least in our transplant unit, are rhinovirus, RSV, parainfluenza, and those are a year-round problem. So I'm not sure it really makes sense to do that. I think if it's a timing thing with a caregiver or with housing, I think then that should really predominate. But I would not let that sway your thinking too much, at least in my opinion.
How often can CAR T be used? How many times? Do we know? Craig?
Yeah, I don't think we know that. I have heard of patients receiving 2 CAR Ts, and actually in the second one, a patient had a CAR T, they relapsed and then went on, I think, a clinical trial. Oh, they were a clinical trial CAR T and then went on, after relapsing, went on the commercial CAR T. That wasn't my personal experience. It was someone I heard about. But again, I would recommend those patients go on a clinical trial if available.
Well, this is the first question I've heard, and I have not heard in 10 of these workshops. Dexamethasone and Zometa seems to be causing gum and teeth pain and swelling. If yes, how can it be treated? Now, is that osteonecrosis of the jaw they're referring to there?
I don't know that that's answerable without a little bit more information.
Okay.
Osteonecrosis of the jaw is certainly a side effect that can occur with the bisphosphonates. Some people have pain when they have that, some people don't, but you would notice like a sore-like feature in your mouth or an exposed area of gum. Dexamethasone has a lot of side effects associated with it. I'm not sure that gingivitis or swelling of the gums, it's not something I think we see often as a side effect of dexamethasone or Zometa, to be honest. But it's probably best to see a dentist if you're experiencing any symptoms like that.
Sure. I think that's part of the whole circle of treatment, how many things you have to pay attention to as a patient. Don't have teeth, you can't eat, and then you lose weight, which probably would help me a lot. But I like my teeth and I need to lose some weight nonetheless. Okay, here's one. It's about herbal medicine. So it is sad, lots of good traditional herbal medicines using human experience over 5,000 years old are disappearing. Current new medical students, I'm curious about your guys' opinion. Students does not study these old medicines. How do I lower my creatinine level under acupuncture and herbal medicines? The man's 75 years old. Interesting question.
I was kind of surprised. I looked at our medical school's curriculum. And in fact, this was just this past week. And the class before me, or the lecture before me, was on herbal medicine, which I hadn't seen that in the previous year. And so I think that, that is because that's a prominent part of medicine, and the patient experience. I think that it is, at least in medical schools, I think really becoming an issue that we need to participate with our patients in. That really, it's not alternative medicine, but more complementary medicine that runs alongside what we do. I think that, I think that I just recently saw that with our medical school.
Oh, that's good, I guess. Well, I have another question, and this might be a kind of a tough one. I have smoldering high risk and live in an area with no clinical trials. Should I try the 2-drug or move to an area with trials? It sounds like he's got a doctor.
I can take this. Yeah, I think smoldering high risk is a controversial area. We didn't talk about this at length, but there have been some studies recently that have shown potential benefit for quote early treatment of smoldering high risk in the highest risk patients with either lenalidomide or lenalidomide and dexamethasone, and there are many more ongoing. This is a tough one, mainly because I personally feel like we shouldn't be dogmatic about this, that every high risk patient needs to get treated, but I think it is definitely worth a discussion. I can tell you many high risk smoldering patients who did progress, and it would have been nice to treat them early, but I also have many that have not progressed, even some on some of these studies where we're investigating early treatment. So I think it is an individualized patient level discussion. I wouldn't say you should move to try it, but I think you should have probably a consultation with a myeloma specialist
Yes.
and review the options, review studies, and just have an informed decision.
Yeah, totally. I think that this is, I think that's become the new bulk of our second opinions, has been in the discussion about smoldering myeloma. And I think we need a lot more research and understanding the biology of smoldering. That what constitutes high risk myeloma, based on the 20-20 criteria. More than 20% plasma cells in the marrow, M protein of 2, and a light chain of 20, is a very gross estimate of risk. There are other more dynamic estimates of risk, including how fast the M protein is going up, and if patients are developing anemia. And so it's not as simple as going on a therapy, and definitely getting a second opinion is super important.
Okay, this is the last question I have, and it's from Mary. A patient asked if they should use a log or a booklet, and would that help your experience with the patient where they say what they're suffering through or they're doing good and things like that?
I think definitely, yes, it can be very helpful. And actually, the Nurse Leadership Board is working on checklists for patients to bring to their provider visit, either surrounding symptoms or potential treatment questions. But yeah, writing down what you feel and when you feel it can be very important in us understanding, is this related to the timing that you take a medication? Is it related to one of the myeloma drugs? Is this related to something you're eating or something else you're doing? I always think it's very important.
Oh, that's excellent. And docs, does that help you a little bit when they come in with a journal to tell you what's going on?
Absolutely.
I think that would be a bit better interaction and a better use of time. Well, with all that being said, and using time, everyone that's at their desktop right now watching it, clap your hands. We had wonderful presentations today. I can't say enough for Dr. Cowan and Dr. Cole and Mary. You guys just rocked and helped out a lot of patients. We had a great turnout today, and to prove that, the people who stayed on longer to ask questions and so forth. So thank you. Thank you from my heart. I really appreciate your time.
Well, thank you.
Thank you for having us.
Thank you.
It's an honor.
It's an honor to be here.
Okay, let's go into what we're doing here. We got the video replay and the slides, right? This will be up on our website shortly. I think that one thing that I found really interesting was that more and more people are going to these slides because they can break it down individually. So you don't have 187 slides. You can go to one topic and see it. Now we've had 8 of these this year. So there's 8 different doctors. Or was it 16 then? It'd be 16 different doctors roughly that are talking about myeloma. Nowhere can you get that kind of information. The IMF is information centric. The most important person at the IMF is you, the patient. We work for you. That's what I want to really make the difference there. You need some answers, you can call our info line at 800-452-2873. Or if it's late at night while you're on dexamethasone, you can email them at infoline@myeloma.org. So with that being said, you know what we got to do here. Now, the other part going on to this, your feedback is incredibly important. Don't leave yet. We need you to do your feedback, which will pop up after you sign off. And that will help me understand about topics that we need to discuss, if the program went well and things like that. But please, 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 can't tell you how much that's important to me personally. This information that you give anonymously will help how I'm doing the program and help the IMF cater and structure programs for you as a patient. None of this could be possible without the generous support from our sponsors. Generous, I will say Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, Takeda. Thank you for what you're all doing in the myeloma world. It's making a better, it's helping make better patients. Now, the last slide here. Whoa! Go to myeloma.org when you're staying up late. Be quiet. Don't do dishes on dexamethasone at night. It always kind of causes a little rift between families. Go get these booklets. They're online, or you can go to myeloma.org and order them. We give you hard copies. We give you computer copies. You can go over to videos. There's Dr. Joe McHale. There's Dr. Dury. These people know what they're talking about, and they're here to take care of you, period. Period. My name is Kelly Cox. I'm the Director of Support Groups and Regional Community Workshops. I've been doing this for many, many years, and I'm always, always humbled by how many people attend these programs. Thank you from my heart. I look forward to seeing you soon in another program.